Next, I want to talk about combination therapy and sequential therapy. I kind of already mentioned when we were talking about each drug that we may follow one drug after another, but here I kind of want to summarize it and give you data on which combinations or sequential therapies we have already studied. And when we look at bisphosphonates, we look at the effect that it has at 5 years versus 10 years. Here specifically, we studied alendronate. Now, when we're looking here on the left, they measured the bone density of the femoral neck at 5 years here. When alendronate is continued, there's, I guess, kind of a plateau effect here, but there's still a bone mineral density that's increased or a little bit increased or at least stayed the same versus placebo. Here is where the alendronate was removed. The patient wasn't taking anything. You can see there's a significant decrease in bone mineral density from 5 years to 10 years. On the right here, we look at the lumbar spine bone mineral density. At 5 years, if we continue alendronate, we see a little bit of a increase that continues past the five years. So maybe in a patient that has already very low lumbar spine density or has a fracture there, they might benefit from 10 years versus 5 years. Because if you look at someone who is on the placebo, once that alendronate is stopped at 5 years, there's a little bit of increase, but really kind of just stays the same up until 10 years. So that's something to consider, looking at the differences between stopping at 5 and 10 years, and then that helps us decide how long a patient should continue this medication, because then what we recommend is what is called a drug holiday. Drug holiday is you're taking a break from taking your bisphosphonates. And like I said, it's going to be different for each agent. For alendronate and risodronate, if you're at a low to moderate risk, that's only going to be 5 years. But let's say you are at a high risk, then you're going to be wanting to take that longer, so 10 years. The IV zoledronic acid, so that's going to be a little bit shorter. So we're only doing that for 3 years. And then if the patient is high risk, that would be 6 years. Once this time has passed, then we start the drug holiday. So during the drug holiday, for patients who are at high risk, it's a possibility, as long as insurance covers it or they need this medication, we could use denosumab, teriparatide, or raloxifene during this drug holiday. And then you would just monitor every 2 to 4 years, kind of looking at any changes. And the duration of this break from bisphosphonates or drug holiday would be based on whether or not the patient had a new fracture, there was a decrease in the bone density, or maybe there was a change in the T-scores that may warrant a patient to be restarted on the med if they were on their bisphosphonate holiday. When you're on a holiday, it doesn't necessarily mean that they always have to be on a drug. Remember, this is going to be, they're going to be on a additional drug after the holiday or during the holiday if they're high risk. But you're low to moderate, you might not need that backup. Now moving on to sequential therapy, kind of similar, where you start with one drug and then you want to follow it with another one. Ideally, we want to do anabolic because that's building bone, and that's going to be followed by an anti-resorptive bone. So the anti-resorptive bone is going to prevent any breakdown of bone that was made by the anabolic medication. However, anabolic medications are going to be expensive. So in practice, what ends up happening is that we end up starting with an anti-resorptive. So some of the sequential therapies that we could use are abaloparatide, romosozumab, or teriparatide. So those are your anabolics. Romosozumab is technically both, and that would be followed by a bisphosphonate or denosumab or raloxifene in that specific population where it would be indicated. We have data for teriparatide being followed by alendronate or zoledronic acid, abaloparatide followed by alendronate, and then romosozumab that could potentially be followed by denosumab or alendronate. Then we also have combination therapy, and that's when we're using two drugs at the same time. Teriparatide and zoledronic acid is one. We could do teriparatide and denosumab, estrogen and an anti-resorptive, or raloxifene with an anti-resorptive. But just remember these two here, we're not going to be using estrogen or raloxifene for everyone. These are going to be only for those patients where it's actually indicated. But right here, I guess this is a good example of why we would want to add an anti-resorptive, because raloxifene doesn't have a good protective or decreased risk of hip fracture if a patient is already on raloxifene. So perhaps we can add an anti-resorptive that does cover the hip. This is a graph that kind of shows what sequential therapy is, or what happens to bone mineral density. So after teriparatide is stopped, so this would happen right at this point at 12 months, we could so there's two different outcomes. There's the teriparatide. Here we're following it with alendronate. So we stop the teriparatide and we continue with alendronate. So we can see that the bone density increases. However, if the teriparatide isn't followed with anything, so that would be this line here. So they're just getting teriparatide, they stop it, and then they get placebo. We do see a decrease in the density here. So this shows why we might want to use sequential therapy, even if we're using one anti-resorptive after another anti-resorptive. It doesn't have to always be an anabolic and then an anti-resorptive. Now this depicts the benefits of using combination therapy. So specifically, they studied zoledronic acid with teriparatide. On the left, we have looking at the density in the lumbar spine, and the green represents zoledronic acid alone. The orange here is teriparatide, and then the yellow is the combination. What we found is that there was a statistically significant difference in this one and this one compared to zoledronic acid. So there's better benefits in density when we're using teriparatide, or if we're using zoledronic acid with teriparatide, and that would be this point here. And then when we look at the right here, measuring the total hip bone mineral density, it was statistically significantly different here when we're comparing zoledronic acid alone to teriparatide. So this is teriparatide, or if we're looking at the combination of the two when comparing it to teriparatide. So these two here corresponds with this point here.